extend to you the most cordial welcome to this International Nurses Day 2026. Every year on this date, this offers a wonderful opportunity to acknowledge and to visibilize and to acknowledge the huge contribution made by the nurses in our region. Before we formally get this going, we'd like to share with you some information. This is being recorded and later on it will be available in the institutional channels of PAHO. We have simultaneous interpretation into English, Spanish, and Portuguese, and to select a preferred language, we invite you to go to the bottom of the screen and then select the language of your choice. Those of you in person, we ask you to select your language in the screen in front of you.
Interpretation in English, Spanish, and Portuguese. To select your preferred language, please use the interpretation icon at the bottom of your Zoom screen. And for those joining us in person, we kindly ask you to select your preferred language on the screen in front of you. So thank you so much.
For those who are connected online, we also have interpretation. You can go to Zoom and select the language of your choice in English and Portuguese.
To officially open our event, it's my pleasure to introduce our distinguished authorities to join us at this head table. Dr. Benjamin Puertas, Unit Chief, Human Resources for Health, Mrs. Mary Lou Valdez, Deputy Director of PAHO, and Dr. Cecily Thomas, Assistant Director of PAHO. So thank you very much, the three of you, to join us today. And now we are honored to welcome Dr. Honda Cecily Thomas, who will deliver the opening remarks for this celebration. Dr. Cecily Thomas, the floor is yours.
Thank you, Madam Chairperson. Good afternoon to everyone. I would like to recognize Mrs. Lou Valdez, our Deputy Director, Benjamin Puertas, the Unit Chief, Human Resources for Health for PAHO, all the panelists who have joined us here at PAHO headquarters, those of you joining us online, those from academic institutions, welcome and good afternoon. On behalf of the Pan American Health Organization, I'm pleased to welcome every one of you joining us today, both here at PAHO and virtually, as we commemorate International Nurses Day 2026. We are honored to convene a distinguished group of leaders from ministries of health, international organizations, academia, and clinical practice. Your experiences and perspectives will enrich today's discussion on two priorities that are critical to the future of health systems in the Americas: health workforce planning and the expansion of nursing roles. These are not theoretical issues. They are at the center of the most pressing challenges facing health systems across our region. The Americas are experiencing profound demographic, epidemiological, and social shifts. Rapid population aging, the rising burden of chronic diseases, and persistent inequities in access to care placing growing pressures on our health systems. At the same time, structural constraints within the health workforce, particularly in nursing, continue to limit our ability to respond effectively to these challenges. Shortages and uneven distribution of personnel, gaps in educational capacity and regulation, and inadequate working conditions affect not only the nursing profession, but also the accessibility, quality, and continuity of care. Addressing this reality requires moving beyond isolated initiatives, but towards coherent, strategic, and integrated workforce policies. Strengthening health workforce planning is essential to anticipate future needs, align education with service delivery priorities, and promote a more equitable distribution of nursing personnel among all levels of care. Equally important is the expansion of nursing roles. Advanced practice nursing offers a proven, evidence-based approach to expanding access to services, particularly in primary health care. Advanced nursing practice strengthens care through increased clinical competencies, enhanced care coordination, and greater professional autonomy. Their leadership is indispensable to building health systems that are more responsive, efficient, and centered on people and communities. Progress, however, depends on creating enabling environments. This means investing in education and training, strengthening regulatory frameworks, and ensuring that working conditions allow nurses to practice to the full extent of their competencies. These priorities are closely aligned with PAHO's policy on the health workforce 2030, which calls for stronger governance, improved planning, and more effective use of the health workforce to advance universal health care. Today's event provides an opportunity to exchange experiences, share evidence, and reflect on progress across the region. In closing, as we celebrate International Nursing Day, I ask that we take the time to look beyond policies, regulation, educational capacities, and working conditions, and see the real persons and the human element of the nursing profession. Let us remember that nurses are men, women, who are mothers, fathers, children, who have families, who have feelings, and have needs that go beyond the usual policies and other necessary enabling factors that enhance their work. I therefore hope that the discussions this afternoon will inspire continued collaboration and reinforce our collective commitment to strengthening the nursing workforce in the Americas. Thank you, and I look forward to the discussions this afternoon. Thank you so much.
Thank you very much, Dr. C. Thomas, for your inspiring remarks and for highlighting the strategic importance of strengthening and investing in nursing across our region. So we would also like to thank Mrs. Valdez and Dr. Portas for their presence and participation in today's event. So we start now the International Nurses Day. Thank you so much. Ahora damos inicio a nuestro
And
primer
now,
panel.
we call to order the first panel.
Ahora damos inicio a nuestro primer panel.
Let us now begin panel 1, Nursing Workforce Planning Pathways toward Resilient Health Systems. And for that, it is a pleasure for me to invite once again Dr. Benjamin Puertas, who is the Unit Chief of Human Resources for Health at PAHO, who will be moderating over this panel. Thank you very much, Dr. Puertas. Please proceed. Thank you very much. And once again, my gratitude is addressed to PAHO officials who were with us at the beginning of the ceremony, which is repeated every year. And for us, this implies being able to embrace from a distance hundreds and sometimes thousands of nurses, men and women and people interested in nursing, and who join us here both in person as well as connecting virtually. The first panel is Nursing Workforce Planning Pathways toward Resilient Health Systems. And we will kick this off with the first panelist. Let me introduce Dr. José Luis Cobo Serrano, President of the International Council of Nurses. Dr. José Luis Cobo is a nurse, PhD in nursing, and with an outstanding background in teaching and research in health. Currently, he is the president of the International Council of Nurses for 2025-2029, after having established the board between 2021 and 2025. In Spain, he occupies the position of vice president of the General Council of Nurses since 2021, and is a member, full-fledged member since that time. Recognized because of his commitment with professional excellence and evidence-based care, Dr. Cobos is an international reference in the strengthening and strategic development of nursing. This will be our first panelist, but it is also a great honor to have with us other distinguished panelists who are with us now, such as Mr. Sean Chilton, Chief Executive Officer of Health Workforce Canada, who's with us in person. Sean Chilton. We also have connected virtually. We have Chandrut Persson Bahadur, Director, Training and Education, Ministry of Health of Guyana. And also for the comments and final thoughts, we have Ms. Ana Emilia Solis Ortega, PAHO WHO representative in Honduras. So let us get this going, and then I will be introducing each one of the speakers. I've already done that with Dr. Jose Luis Cobo Serrano, and we wish to welcome him, and he will make his presentation connected virtually. And you have 10 minutes for that. Please, Dr. Cobos, please proceed. Thank you very much, Dr. Benjamin. For me, it is a great pleasure to be able to be with you on this very important day for nurses in the world. Greetings to all the officials, all the officers, all those who are present in the room, and those who are connected from a distance. I'm greeting you from Geneva, Switzerland, our headquarters at the International Council of Nurses that brings together 30 million nurses all over the world. And we represent the voice of 145 countries. The fact is that it is truly a pleasure to be able to have this opportunity, because undoubtedly this is a day in which we analyze a lot of things, and this webinar will help us do that. And with your permission, let me remind you what the slogan for today is of the International Council: our nurses, our future. Nurses empowered to save lives. So this is a message that has a lot of meaning, but also a lot of scientific evidence, as is shown by the document that we've developed and published. But before I do that, let me show you a little bit what the current situation is. We live in a world full of challenges, economic, social, technological, environmental challenges, and that has an impact on health and on health care. Progress has been made and improvements have been achieved, but it seems to me that we have to continue moving forward and making progress. So we see the nurses, and it is the largest number of health professionals that are not duly valued and that are not duly protected. We also see a huge inequality in health professionals in the world, because, for example, 40% of the 35 countries of the region of Bajo have a density of less than 3 nurses per 1,000 inhabitants. But if we take a look at the map, the global map, we see huge differences. The report that was produced together with the World Health Organization on the status of nursing in the world, and that was published last year, already warned us that in only 4 years, by 2030, we will be missing 6 million nurses that will be needed in the market. And this shortage is even more serious in low-income countries where these needs are more urgent. Instead of improving the training of nurses in your own countries, in many countries, what they do, particularly the rich, is to resort to the workforce in the countries with less economic capacity. And that is giving rise to a lot of migratory movements that are of concern to all of us in this pressing situation. So we're promoting what we call an ethical hiring, and for us not to decapitalize the health professional in some countries, particularly in some countries like or India. It is a challenge that we have ahead of us, and we've come to realize after several surveys and polls that the demands are greater, and the representatives of the nurses in each country in a poll told us that there's a significant increase in the demand for nurse professionals. But the response capacity that we have is not adequate. There's a significant gap between the supply and the demand. Our report of the International Nursing Day shows a clear evidence showing that the power of nursing is real. It is not an invention, and it has been quantified. And it is a transformative element that the world cannot simply overlook or neglect this. So the report shows that every day in all the regions of the world, in all our surroundings, nurses save lives. They protect communities, and they keep united all health systems that are often under great pressure. And this report collects 7 huge powers with the scientific evidence. And I will just mention this in passing because we don't have a lot of time, simply to give you an overview of these. The first one is the power of trust, because it has been proven that patients in all polls have a high rating given to nurses, and when there's confidence, when there's trust, health improves. And when they have confidence in us, more patients or more people get vaccinated, they get immunized, and that's a clear power or a clear proof of the power of that confidence, or the example of professionalism, because it has been shown that professional nurses with better training, with better qualifications, are better prepared in order to reduce mortality and morbidity. And also the power of figures, of numbers, because it is important from a qualitative point of view, as we saw previously, but also quantitative. We need to increase the ratio of nurses at the power of practice, because if we allow nurses, and this was said in the introduction, will include new skills, advanced practice, and we are certain that we will have more effective and efficient health systems. At the power of care, an essential power in order to take care of the population. Health, universal health coverage, a target that we've all set by 2030, and primary health care plays an essential role, or the role of closeness, because it is obvious that nurses are an initial point of contact with health systems all over the world. And last but not least, the part of peace. Peace, which is ever so more important, particularly nowadays in times of crisis, of humanitarian crisis. Nurses can launch a huge campaign that we've set in motion of Nurses for Peace, because if we don't have peace, we don't have health. And we're not talking about parties or sites. We take care of everybody, all those who need our care, but we cannot allow people to attack the nurses or health professionals or our facilities. So this is a summary of what the 7 powers that we've shown with scientific evidence. And these have been enshrined in our document, because when we invest in nursing, we obtain wonderful results. So we reduce mortality rates, but we improve clinical results, interventions in public health which are more effective, a greater security and certainty of the patient. So we have a whole wealth of justifications as to why we have to invest in nurses and why nursing must be empowered. And I'd like to conclude, because this report, as I was saying, gives us a lot of tools. But one thing I must say, and this is addressed to governments and to authorities, suffice it to hear words. We're all saying that we're the spinal column, that we're very important, but this has to be translated. All these policies have to be translated into facts that will truly be invested in nursing, and that they will sit us at the table where decisions are made. And then nurses, men and women nurses, have to believe that. We believe that investing in nursing is the most effective way of raising that influence exerted by nursing. And when the nurses receive support, this is duly valued. Power is given to them, they provide outstanding care, and they help forge a healthier future for our population. Nurses, empowered nurses, save lives. Thank you very much, and happy Nursing Day.
Muchísimas gracias.
Thank you very much, Dr. José Luis Cobos Serrano, who's made a presentation based on the powers given to the nurses, the men and women nurses. And in fact, this is a way of positioning that wonderful work that is played by this professional, something that goes beyond the care that they give, and it covers elements such as those that he mentioned: confidence, closeness, peace, and that is a much more holistic approach. Let me continue. Now I'll switch to English.
Now we have the participation of Mr. Sean Chilton, who is in my left, Chief Executive Officer of Health Workforce Canada. Sean Chilton is a registered nurse and seasoned health executive with over 3 decades of progressive leadership across one of Canada's largest and most complex health systems. Prior to joining Health Workforce Canada as CEO, he served as Senior Vice President of Clinical Operations with Alberta Health Services. Sean is known for driving transformational change, building high-performing teams, and delivering strategic results in dynamic, high-pressure environments. Sean Chilton is going to present us with a panel on data and intelligence for nursing workforce planning in Canada. So very much welcome, Sean, and the floor is yours. Just 1 minute until we download the presentation. Meanwhile, it's a time to look at your left or your side, and probably you'll find somebody who loves nursing or who understands its power.
Thank you, Bruno. Good afternoon, and really thank you for the invitation to speak here today and to be here in person. Thank you for the hospitality of PAHO for making this actually a really memorable trip. And for me, being here today is really important as we mark International Nurses Week and International Nurses Day. It makes this conversation especially meaningful for me, as was said by Benjamin. I'm a registered nurse by background. My family are all registered nurses. My daughter's a registered nurse. And it really has helped shape how I think about care teams and how I think about health systems. And I think that's really important as we talk about health workforce planning. Today, I'm going to share how we're thinking about health workforce data and intelligence in the Canadian context. And I'll use nursing as a practical example. But with lessons that extend well beyond nursing. This isn't just about one profession, and I think it's well beyond one country as well, and I think there's lessons that we can all learn from each other. It's not a technical presentation, so if anyone was expecting lots of data, that's not what I'm going to give. But really, I want to talk about how we move from having data to using intelligence to really plan for care, which is what we're all here to be able to do. So, like many systems represented here today and around both the in-person and the virtual table, COVID-19 pandemic really did create in Canada a workforce challenge, and it didn't create the workforce challenge. I think what it did was expose and accelerate them. I think it brought lots of attention to an already pressured system. The Canadian context, and I think it was similar across the world, we saw job vacancies rise sharply. We saw a significant reliance on overtime increases, and we actually started to see what we call itinerant and agency staff. So those are professionals that are hired from companies and organizations, private companies and organizations, to come in and provide that care and support. And I think those are patterns that are seen internationally. Our starting premise is simple as an organization, and that is shortages themselves are not the problem, but they are a symptom. And that data alone won't fix the issue. It will help, but if we only focus on counts, we actually miss what's actually happening in care delivery, and I think that's really important as we look to the future. Just a little bit about the Canadian context, and I don't think it's very dissimilar to many of the members of PAHO and those that are here today, but Canada is a federated health system, and responsibility for healthcare is shared across governments and sectors. There's lots of data that exists, and in many cases, it's actually really good data, but it spreads across education, it spreads across ministries and governments, it spreads across regulation, employers, and across different jurisdictions. And what's missing in the Canadian context is really a connected view, and that's something that links workforce supply, population need, scope of practice, models of care, and workforce experience together. And so while fragmentation is real, I would say that the deeper issue is that the fragmentation is structural, but intelligence is a design choice, and I think we have the opportunity to move the dial if we think about workforce planning in a different way. Health Workforce Canada is a small organisation. We are funded by Health Canada, thankfully and graciously, and we were created to help bridge that gap. We're only 3 years old now. We were formed right on the tail end of COVID, and we're seen as an opportunity to maybe bring a pan-Canadian lens to health workforce planning in the country. Health Workforce Canada doesn't own data. Our role is to bring the evidence together. We bring data from many of our data partners, the primary keepers of that data. We bring people together, and our hope is that through those two things, we can actually enable better choices. For us, convening really matters as much as the analytics. Convening means bringing together governments, it means bringing together educators, regulators, employers, unions, and professional leaders, because we believe that they all hold part of the answer to the challenge that we're trying to address. And numerical forecasts alone aren't going to be sufficient to address the issues, and effective planning also requires understanding the skills, understanding the roles, the productivity, and the employer, the service organisation that people are working in if we're actually going to do it well. At its core, Health Workforce Canada's work is about trying to enable a shared understanding. I think as an organisation, we've done a great job on tools, so we have lots of dashboards, we have lots of some modelling and forecasting that's available, and if anyone's interested, you can just go to the Health Workforce Canada website. It is all free, it's all there for you to use. In fact, much of our raw data is available for people to download if they want to look at that themselves. But for us as an organisation, while we maintain those resources, further enhance them and refresh them, our big focus now is about how do we help with the people changes that are actually going to be needed to achieve progress. Our strategic priorities reflect what we hear quite consistently from our partners across the country, and that is, yes, better data is important, and in fact, we just, as an organisation, released a pan-Canadian data strategy that was co-designed with partners, over 50 different partner organisations from across the country, to help address the fragmentation that we see that exists in that federated health system. But what we consistently hear is that people need help with modelling and forecasting, they need help with mechanisms to share what works, and they need places to actually have conversations and work through the trade-offs together. And we do that on a foundation of equity, diversity and inclusion, and a commitment to truth and reconciliation. For our Indigenous peoples within the Canadian context, because workforce planning, we believe, ultimately shapes who gets access to care and how they get access to that care. So nursing supply in Canada, overall nursing supply is increasing. It's roughly in line with population growth, actually, interestingly enough. Some roles are actually growing more quickly than other roles. One of the big areas that's happening is nurse practitioners, which is music to my ears, and I think really an important strategy. It probably speaks a little bit to how models of care are starting to change as well. Most nurses we see remain in direct care delivery and not in administrative roles. But what I'd like to draw attention to is that headcounts alone don't tell us where the pressures are, how those pressures are being relieved as we've grown the population, where it's being displaced, and how care is actually being experienced by patients and families. And that's the limitation of data without actually adding that intelligence to the conversation. Nurse practitioners, I think, illustrate this really well in the Canadian context. We see a significantly increasing growing supply, but at the same time, we're also seeing rising vacancies in the nurse practitioner world. We're also starting to see nurse practitioners work across multiple settings and models of care, although that's different from province to province and jurisdiction and jurisdiction. The jurisdiction I was in had a very heavy population of nurse practitioners in acute care hospitals doing specialty care. whereas some of our other provinces, we're seeing, British Columbia, for example, we're seeing significant use of the nurse practitioner in the primary care setting. Often, and I often tell the story, often in our rural locations, what we would hear is when a rural community can't recruit a family practitioner, they say, well, let's go and recruit a nurse practitioner. And my argument would be we need to change that story, and it should be how do we find the best primary care provider for a community and start thinking about whether that's a nurse or a physician. It's about the care needs of the population. And I think we really need to start telling that story and changing that conversation. I think to plan effectively, we need to understand that nurse practitioner growth actually is directly related to the registered nurse pipeline. And if we're not doing one, we're actually not going to do the other, or one will impact the other. Policy and care models will shape whether supply translates into access, and I think that's a really important concept. And numbers alone won't tell us what the system pressure is that we're trying to relieve. We actually need to have the conversations with the people, with the communities, with the patients, and with the employers. In other words, data can show us really good trends. It can help us ask the additional questions, but intelligence, those conversations are really what connects those nurses to the care that we're trying to provide. So telling the data story, I don't think this would be a surprise to anybody, but decision makers rarely ask for raw data sets. They ask questions. For us as an organization, what's really important is transforming that data into intelligence requires interpretation, it requires context, it requires narrative, and it needs to be about how we actually tell the story. I think that challenge is universal. How many people within the room who are in those roles get asked for data, and you provide the data, and someone looks at that data and they tell a completely different story to the one that needs to be told because it lacks the context and it lacks the story that we were trying to tell about what the issues and challenges were that we were facing. One of the things that, again, we're trying to do with Health Workforce Canada, and I'll be honest, we haven't got this right yet. We're in the early days, but it really is our focused effort and attention. And traditional nursing workforce planning often asks how many nurses do we have, where are they? What we want to do is shift that thinking and start thinking about it in an intelligence way. So what do nurses actually do? What they could do under different models of care, and where expanded or optimized roles could improve access and equity. And if I could just give you a kind of a real life example, in the organization that I worked with previously, we had 2 hospitals. They had the same number of emergency visits, they had the same number of staff that were working, but one of those facilities kept telling us that they were struggling. They couldn't actually meet the care needs of the patients, whereas the other one was doing really well. One was having significant overtime utilization, they were getting significant burnout from their staff, and we couldn't figure out what the problem was. So we started to have the conversations. And as we talked to them about the conversations, what became clear, although they were nurses, they were all registered nurses, although they were all registered in the same province, they were actually not practicing to full scope. And in fact, what it was nurses in one site weren't actually able, they weren't being allowed to do everything that they'd been trained to do and skilled to do. And without the conversations, we would never have actually uncovered that. We'd have looked at the numbers and said, there's another problem, there's a management problem, there's another issue. And it actually had nothing to do with that. It was about the culture and what we were allowing nurses to do, and were we allowing them to work to full scope of practice. And that's why the conversations actually really matter in real life. So, what can I say? Workforce planning shapes both care delivery, and it really actually shapes careers. And I can say that from a personal perspective and from a family perspective. I've seen it front and center. Numbers alone can't explain why people stay in the profession. They can't explain why they leave. I told the story about my daughter being a nurse. She actually called me 3 months into work and was ready to quit. She didn't feel adequately prepared, she didn't feel adequately supported, she didn't feel that she was ready to take on a role as a qualified registered nurse. And we need to understand those things. We don't understand sometimes what makes nursing a profession that people want to stay in. And usable intelligence really reflects that lived experience, that professional judgment, and that local context. And when nurses see themselves in the information, they start to trust the work that we're trying to do. Leaders face complex questions. They don't just face technical requests. And I just wanted to highlight this as one of the innovations that Health Workforce Canada has been able to implement. And as I've said, there's lots of evidence out there, but it's often difficult to access, it's often difficult to synthesize, and sometimes it's difficult to apply. And so as an organization, we're actually using digital tools, including curated AI, to shorten the distance between trusted, curated evidence and real decisions. And we're doing that with governance, transparency, and professional judgment at the center. In essence, what you can do in the example that you'll see on the slide is a question just typed into the digital front door, how are jurisdictions changing their use of nurse practitioners? And what the tool will do is it will go out and it will look at all our curated data to tell you what some of the leading practices are, how nurse practitioners are being used. And that kind of intelligence is really, I think, how we start to shift the conversations away from recruiting more nurses towards redesigning teams, redesigning roles, focusing on priority areas such as rural and remote workforce, thinking about the education to workforce pipeline, which is often planned in silos. But technology supports leadership, it doesn't replace it. And I'd like to just close with kind of this thought. Workforce planning is ultimately a leadership act. And I think that's why people around this table are engaged. It's about leading. Data helps us describe problems, but intelligence will help us design the better futures. And as I said, we're still in the early days, but it does require us to, it requires trust, it requires convening, and it requires a shared responsibility. And it's work that no country can do alone, one jurisdiction can't do alone, and I think there's a lot of opportunity to learn from each other in webinars and sessions like this. And with that, I'll turn it back to you. Thank you.
Thank you very much, Sean, for this journey through not only how Health Workforce Canada perceives nursing, but also the stories you told us. I'm still curious about what happened with your daughter after the talk. But I think that's what we need, to have the human face, not just data. And Health Workforce Canada and the presentation of Sean guided us on how this raw data can become really a house, a picture that can be presented as such to the national authorities that have the power to make decisions and to advance policy making. So I think that's the main message from his presentation. So thank you very much. I'm going to continue in English to introduce our next panelist, Dr. Chandruti Persod Bahadur. He's the Director of Training and Education at the Ministry of Health of Guyana. Dr. Chandruti Persod Bahadur works at the Ministry of Health, where she leads national initiatives in health sciences education, including nursing, allied health, and technical training programs. With more than 20 years of experience in education, curriculum development, and educational leadership, she has held senior positions within both the Ministries of Health and Education in Guyana. Dr. Persod Bahadur holds a PhD in management and has contributed extensively to strengthening nursing and allied health education through decentralized and hybrid learning models. She is also an active member of the Nurses and Midwives Council of Guyana. So we welcome Dr. Chandruti Persod Bahadur with a panel on national strategies to increase nursing workforce density. Welcome, Dr. Persod Bahadur. You have 10 minutes. Can you hear us from here? I think you are muted. If you could unmute yourself and we can listen to you. Still nothing. If you're trying, could you please unmute your microphone? Uh, Dr. Shadruti, we are going to put your PowerPoint presentation from our side, if that's okay, and you unmute your microphone and we can start.
When you have,
Oh, here we go. We can hear you now.
you can hear me now. Good afternoon, everyone. It's indeed a pleasure for me to join the panel to share my presentation this afternoon. And I'll be presenting on national strategies to increase nursing workforce density. And my focus would be in Guyana as it relates to that presentation. To continue, I want to share a bit about healthcare in Guyana so that you have the context as to which I'll be presenting. So healthcare in Guyana, it's public healthcare. We have levels 1 to 5, which includes our health posts and our respective health centers. Currently, we have 32 hospitals and 372 health centers within Guyana. As you're aware that we have massive expansion in healthcare facilities, and in 2025, the government of Guyana would have established or commissioned 6 new regional hospitals, as well as 7 hospitals currently being constructed. The little map of the site shows that we have 10 administrative regions in Guyana, and public health services are free within all 10 administrative regions. And we're very generous. We also extend our services to visitors and migrants. To move on, we know that healthcare shortage is a global issue, as PAHO WHO estimated that from around the year 2030, we'd have a shortage of nurses, about 4.5 million nurses by 2030. I want to share with you some of our stats as it relates to nurses within our country. And the blue represents the actual amount that we're supposed to have. That's the ideal. The orange states to us the current staffing, and we also have in green the deficit staffing. So I want to zero in a bit on the deficit, and I choose these 3 categories because we know that registered nurses, midwives, as well as nursing assistants are very important among several healthcare workers. So in Guyana, for our registered nurses, we have a set deficit of 1,629 personnel at this point in time. For our midwives, we have a deficit of 707. And for our nursing assistants, we have a deficit of 994. So indeed, this is a great shortage in our nation, which we realize. So the shortages are basically from 3 major challenges that we would have had. And I'm sure that these challenges are not unique to Guyana. It's globally and it's also regionally. One of our major shortages due to migration challenges, and then the number of persons that we train our output, as well as the growing national demand that I would have alluded to a bit earlier with all the new hospitals and the services that we provide. Consider this, the government of Guyana would have developed some retention strategies, and I'll share a few with you. This is actually working towards curbing persons to stay within our system. So we have increase in salaries. That's ongoing, and it varies from different categories of healthcare workers. In terms of our free education, over the last year, the government of Guyana would have made education at the University of Guyana, including master's degree, PhD, first degree, absolutely free. So persons are encouraged, our nurses, our healthcare professionals are encouraged to utilize those facilities. For persons who choose to go out of our coastline and to our hinterland regions, you have Out-of-town allowances, as well as our senior nurses, are entitled to duty-free concession when purchasing a vehicle. We also have allowances, monthly allowances for persons who would have attained master's degree and a PhD level. You have monthly allowances added to your salary. And because we know we have nurses who work night shift and it's a challenge sometimes to find daycare facilities for our children, the government of Guyana would have also instituted daycare facilities for our nursing professionals, which is a safe space for their children. Continuing, this aspect here actually dealt with the retention strategies. And as I would have said earlier, with the expansion in healthcare, definitely there will be the need to train additional workforce within the system. So I must say on the onset that we are very grateful for the partnership with PAHO WHO, and especially for the partnership in introducing to us the hybrid nursing education model. Currently, this model works very good for us, and it has 4 major components to the model. PAHO has been very, very instrumental, as I said, in assisting us in getting this model up. So the first entity or the first component of the training model is that we have pre-recorded sessions for the theory of the course that is uploaded on the Coursera platform, where we have a special section within that platform to actually assist us in doing our content. Mind you, the content is locally developed by all our facilitators that we have, and the scenarios are reflective of the situation in Guyana. To aid this online component, we also have tutorial sessions. These tutorial sessions are virtual live sessions in which students can actually assist each other, peer learning, and they can have clarity in terms of any misconception they would have had or any justification that they need to have as it relates to the content that they would have read on the platform. After this, we move to simulation centers. And investment in education is very important if you want to have expansion in terms of human resource development. The government of Guyana would have provided the necessary equipment and all that we need to have simulation labs in all 10 administrative regions within Guyana. So our students are in their respective location. They go to these sites. It's flexible to their planned dates. They go to these sites and they select their timing, and they're being guided by faculty members in the simulation centers. After that, they're prepared for their hospital rotation, and this is also done within their region to have that hospital rotation, but it's guided by our mentors that we have and our senior nurses within the health sector. If you zero in a bit close to the picture at the back, we were very honored and privileged to have Dr. Barbosa, who's the director of PAHO, in one of our simulation facilities, and he interacted with our students. And we also have the Guyana PAHO representative, Dr. Kim Dixon there, who also supports this project. So indeed, the hybrid approach or the hybrid method of training would have significantly impact all that we do as it relates to the development of our human resource and the services that we want to provide. So previously, we had 3 nursing schools of education, which would have provided in-person sessions for our students. Approximately 200 to 250 persons would have been trained annually. Persons living in rural areas had to leave their homes to come to these training sites for approximately 3 years. And the equity of it wasn't there when we look at the in-person training program, because all of Guyana, persons who want to do different training programs were set in the confines of 3 classrooms. So we had to find another solution as to what would work for us. So the online hybrid nursing program allows us to decentralize training across these regions, and it ensures equitable distribution and opportunities. From this approach, it also reduces attrition rate. We would have had more persons completing training programs and a variety of areas using the hybrid approach. It also have persons who are entitled or persons who are enrolled in these programs. The government would also employ these people at the end of the training program, so our students have a place in the system. Of course, we have challenges because it's hybrid, it's new. We have connectivity issues, that is internet access. But aided to this process is that the government of Guyana would have already set up several telemedicine sites and internet hubs. So our students from the different locations, they utilize these sites, they download their content and they study in their own space. It's a very flexible model. They also, after completing their training, the Nurses and Midwife Council of Guyana offer their license to practice, and they're there assisting in the system already. I just want to briefly show a comparison of the impact that the hybrid system has on our workforce. So from 2020 to 2025, we trained 401 registered nurses. So in 2026 of July this year, in this year alone, we are expected to graduate 680 registered nurses. In my previous slide, I showed you a deficit of 1,629 registered nurses. So added to the 680 students that we expect to graduate in 2026 this year, we also have 510 students and another 600 registered nursing students in 2028. So this puts us in a good place as we approach 2030. And this is not only for the registered nursing program, but we also saw significant impact with the nursing assistant training program. So from 2020 to 2024, we had 592 students who graduated as nursing assistant, compared to in 2025, when we utilize a hybrid approach, we were able to graduate 1,267 nursing assistants, and currently we have 350 students in training. I want to reassure you that while our numbers are upscaling, we are moving vastly. There is no compromise on the quality of training that we provide. We have continuous assessment as well as in-person and physical practical examination for our students. I want to leave with you that indeed the hybrid training model is very transformative, and it would have provided a pathway for us to address our human resource gap in Guyana. Thank you very much.
Thank you very much, Dr. Chandruti. And really, for PAHO, it has been quite an honor to work together with Guyana in this wonderful training program and training nurses. As we mentioned, I think it's important to mention that Guyana has a population of less than 1 million people. So those numbers that you see here, that in Brazil could mean not much, but in Guyana, it's a whole number. I mean, there's a lot of nurses being trained in Target, and with the collaboration of PAHO and PAHO Collaborating Center, which is the University of Sao Paulo in Ribeirão Preto, which is a nursing collaborating center. I think that's a partnership that is really moving this initiative. So thank you very much, Dr. Chandruti. And just to mention that PAHO is publishing the history of this case study of Guyana because we think it's an experience that needs to be shared as a best practice, as lessons learned, and shared with other, not just Caribbean countries, but countries in general in the region. So congratulations to Guyana. So we're moving to, finally, we have completed the 3 presentations, and now we're ready to hear comments and reflections from one of our PAHO WHO representatives. I'm switching to Spanish. It's
a pleasure and honor to introduce Ana Emilia Solis Ortega, representative of PAHO and WHO in Honduras, who has been listening in carefully to all of the presentations given by the panelists, and now she has some comments and reflections that she would like to offer from the standpoint of Central America, but with a regional overview. So thank you very much, Ana Emilia. You have the floor. I thank you, Benjamin, for this very worthwhile, interesting morning, and I thank all of the nurses and the presenters. Now, from Central America, I would like to give you an overview of focusing on three of the elements that were brought up in the presentations and that are very important for this region. The first is the difference between planning capabilities and actually having. Canada was put this in very clear terms. The data that was provided about vacancies and staffing, but that falls short when we look at those figures separately from the needs of the population, the care models, and the environment of practice and the territorial distribution for Central America. These distinctions are very important to us. The technical question cannot only be how many nurses does the system need, but rather what solutions need to be addressed at each level of care. What are the skills that are needed for these functions? What tasks could be redistributed or broadened, and what conditions would make it possible for that capacity to actually be brought to bear where it is most needed? This has to do with expanding the healthcare system and how long that's going to take. Now, we saw a very worthwhile presentation about Guyana, and this is an experience that combines building up the infrastructure, ongoing training, and retention incentives, and so that lesson is very important. Infrastructure and the labor force have different schedules. They operate at different schedules. You can't have the infrastructure before you have the staff to actually work it. And otherwise, when that happens, then that brings more pressure on those who are currently working. They're overwhelmed, and that makes it hard to keep up continuity and quality. That's why education and nursing training has to be built into the early decisions made about expanding the infrastructure, and it can't be an afterthought just by way of some type of operational adjustment that's made after the fact. The International Council of Nursing reminded us today that the world distribution of nursing continues to be unequal and that migratory trends are a key aspect of this discussion. In Central America, that calls for a very strategic outlook. These are individual decisions that are legitimate regarding the staffing, but there's also going to be different in the professional career and tenureship and working conditions and salaries, and also opportunities, possibilities for training. Regionally, we can't just think that by training more, however necessary that is, will be enough. But it has to be done better. That's also strategic. And now we have a very important opportunity for Central American Isthmus region to move forward with this shared agenda, planning our HR with compatible information, establishing priorities, territorial incentives, and strengthening the public careers. Now, there's another matter I would like to address regarding first level of care. For years, our systems have associated a greater professional recognition with the hospital and the specialized care where they work, and this has an effect on incentives and how we appreciate the work that's done at this first level.
However, if countries want to have integrated networks of primary healthcare and financial sustainability, the first level needs capacity to solve things, which is much stronger. And that implies nursing with a clinical leadership, expanded skills, professional development, and institutional support. Last but not least, I wish to highlight a cross-cutting element in the three presentations, the planning of the human resources. Manpower cannot be dealt with exclusively from the health sector. It needs articulation between health, education, professional regulation, public funds, universities, and regional integration mechanisms. And in all that, technical cooperation plays a very important role. From PAHO, we see this conversation as a core issue of the agenda for strengthening healthcare systems for primary healthcare and health regulations. Perhaps one of the most relevant conclusions of this panel is that the discussion on nursing must be included much closer to the spaces where decisions are made on development, on financing, and on the organization of health systems. Have a happy Nursing Day. Thank you very much.
Muchísimas gracias a la ingeniera.
Thank you very much, Ana Emilia Solis, the Tajo WHO representative of Honduras. From Tegucigalpa, she was sharing with us the approach of the Central American situation. And now we're coming to the end of this panel. And for the over 1,500 nurses, men and women, people interested in the nursing profession who are with us today, to all of them, let me tell you that it is important to have you with us. We thank you for your presence from many countries, not only in our continent, but from outside the continent. And for those of you who are connected virtually, I want you to know that here at our PAHO headquarters, we have a group of professionals, of people completely connected and involved in the development of nursing, training as well as practice. And you might be connected virtually, but we're all speaking the same language and looking at one same challenge. And with that, I'm very grateful to the panelists who were with us virtually, to our friend and colleague, Sean Chilton, who's been here in person. And let us move on to the next panel. Thank you very much.
Muchas gracias, Dr. Puertas.
Thank you very much, Dr. Puertas, and also thank you to our distinguished panelists for this excellent and very enriching session. And now we move on to panel number 2, Advanced Practice in Nursing, Transforming Models of Care and Expanding Access to Health. It is a pleasure to hear Consuelo to learn lessons learned from Chile in the implementation of advanced practice nursing. Consuelo is a nurse, a master's, a PhD in nursing by McMaster University in Canada. She's an associate professor of the School of Obstetric and Nursing University in Chile, the Andes University. Consuelo has an outstanding background in academic leadership and strengthening of human resources in health, has played a key role in promoting advanced practice in nursing in Chile, developing the first program in the country and cooperating with strategic elements in the Ministry of Health. Maria Consuelo, thank you very much for being with us here today, and you now have the floor.
Muchas gracias. Bueno, muy buenas tardes, feliz día, queridos colegas.
Good afternoon, happy day, dear colleagues in Latin America. Thank you very much for the invitation extended by the Pan American Health Organization so that I can share the Chilean experience in the implementation of advanced practice in nursing. The first thing is to let you know that the presentation was structured as follows. Let me start off by telling you a little bit of the history of advanced practice of nursing, then the successes in development and the lessons that we've learned in the course of this time and the challenges that we have ahead of us, which are many. It is difficult to summarize what has been the development and this work in order to promote advanced practice nursing in our country. It's been going on for over 15 years, but these are the main milestones that on the one hand has kicked off the development of this APN and then given a new push to its development. In 2011, we had the creation of the first program in our country in Latin America. In 2015, the summit organized by McMaster University and PAHO in order to promote the development of APN in Latin America as a strategy in order to strengthen primary health care. And then in 2018, the National Cancer Plan in Chile which included the APN for cancer, the team that dealt with oncology, and last but not least, the creation and consolidation of the Chilean practice on APN. 2011, let me tell you that although it is true that 2011 we had the development of the program, but this was work done by many people before us in 2 years in order to create this program, to create the program with the skills, the competencies, and the definition that had to do with the international level. Then we had a whole work to disseminate the role of APN in our country. First, within the academic community, because it was a role that was not known. We did not have the community of APN in our country, and that was a huge challenge to explain what the role was, what was the evidence that supported this role, what were their competencies in the practice field, etc. And as was stated at the beginning, it was in the academic community, but at an early stage, we understood that the role had to be disseminated through other means. So this is where we bring in everything that has to do with the public dissemination through, for example, writing letters to the director, defining this role, and by involving it in solutions to health problems that we had at the time and everything that had to do with the publications at an academic level, the role of participation in congresses and conferences, etc. And then we had the summit, the 2015 summit, which undoubtedly, this summit that was organized by the Pan American Health Organization at McMaster University, the Cooperating Center, the Collaborating Center, it reflects what has been a constant with the Pan American Health Organization. This partnership has served as a main driving force behind the development of the advanced practice nurse APN. PAHO has been a huge promoter for the development of this role in order to beef up primary health care and to cover all the needs of access and coverage that health care systems have in Latin America. And it was also another opportunity in order to internalize the Chilean model of the exchange of best practices and experiences in the establishment of international networks and the participation of the relationship with experts from other countries that already had implemented this role and had been working on it for some time. And then I would briefly like to talk about the National Cancer Plan. This was quite significant work of nursing. It was collaborative work between nursing schools, particularly in Santiago, the capital city of our country. And here, besides this collaborative work, and in closing the links for the benefit of a common objective, there was a political work that was done, which was very important for us because we had the possibility of participating in technical discussions at a ministerial level where we talked about the role, how the role could be developed of the advanced nursing or advanced practice nurse with the care model, etc. So it was an opportunity to begin participating in the political arena, which was very interesting, and it also allowed us to create networks beyond nursing. We grew up with the establishment of cooperation networks, not only in nursing, but we moved on to cooperation with other relevant stakeholders. And then the things that were right in this development, the creation of advanced practice programs, which has been quite an asset, hit on the target itself, where we established partnerships at a national level, but also at an international level to have the experience and the support of universities that already had experience in advanced practice nurses. Today, we have more than 50 graduates, more than 50 professionals or nurses in advanced practice working with very good results. For example, in following up on people with cancer, people with cardiac diseases, working in emergency services and mental health and intensive care units. And the most interesting things is that we took this beyond the private system. These nurses in advanced practice are both in the public sphere as well as in the private sphere. Currently, we have 3 universities that have advanced practice nursing programs. Another success has been disseminating the role and the impact of advanced practice nursing. And we not only limit this or enclose within the scientific sphere, but we also package this adequately in order to reach the relevant stakeholders in health and in public opinion. Another success in development has been the articulation that was achieved as nurses, as a nursing group, taking advantage of the window of political opportunity that was given to us with the National Cancer Plan. And nowadays, we have many opportunities or many windows of opportunities that we're working on, such as the Health Alert and the Ministry of Health in our country. It deals with this for oncological care, a waiting list, primary health care, everything that has to do with mental health care. So in a context of where we have an urgent need to respond to health demands and to use the management of human resources, and it has been said throughout the presentations this afternoon, there's scarce and spread all over, APN can play a key role. Support also for development has been the figure of the National Nursing Department that has led the development or the discussion on the development of APN to the ministerial board, ministerial discussion, and then creating strategic partnerships between the academic sector, scientific institutions, and the nursing organization. We've taken the leadership to develop advanced practice in our country. And last but not least, the establishment of this Chilean organization of advanced practice, which convenes all those graduating from APN in our country, all the nurses that practice APN in our country, and that has three significant axes of work, which are the following: education and training, that is to say, to ensure quality education, with a view to doing this in the country, the political axis that has to do with the support and the contribution that we can make for the development of policies that support the implementation of the role and the integration of these roles in our health system policies that act at a macro level, everything that has to do with the workforce, financial policies, etc., but also at the organizational level with the development of protocols, guides, processes, etc. And last but not least, the last axis is the research, which is very important to contribute to the development of knowledge and also to have national evidence in order to improve or to promote the development of APN in our country. Very well, so the lessons learned, the establishment of partnerships and networking, very important. And one first attempted between the nurses, but we have to take it a step further and create networking with other important partnerships. We have to take this beyond what is academic. It has to go beyond. We need a political discussion, or we need networking with the political sphere. And in here, we know that the nurses have problems in order to be invited to the discussion tables, as was said previously. But also, I encourage you, because we've done that. So I invite you to organize and develop political dialogues where you invite the relevant stakeholders to talk about the APN, about a better planning of the nursing workforce and how to bring in advanced practice into this workforce. And then to have this APN as a strategic solution in health problems, political and priority problems in each country, the challenges that we have ahead of us, to strengthen everything that has to do with insertion for advanced practice in nurses. So we upon individual initiatives and leadership by each one of us, and how we've been building this place that we find in this market, and the development of our policies, macro and micro, the partnerships with the patients. We still have to work on this so that we can work with patients, research and regionalization. And I thank you very much for the presentation made by Guyana, because clearly in that we have a huge challenge, which is to set up the model of APN in the regions of our country, which are those that face the most serious gaps in personnel distribution. Thank you very much.
Muchísimas gracias, Consuelo.
Thank you very much, Consuelo, for this excellent presentation. Your presentation enables us to become better acquainted about the development of of advanced practice nursing in Chile and to understand how leadership, political articulation, and international cooperation have been essential in order to move forward with the strategic agenda. So it is especially valuable to see how the Chilean experience has evolved from the creation of the first program and the masters on APN all the way to consolidating skills and professional associations and political spaces. Also, lessons learned that you have shared with us, important thoughts that are quite relevant for our whole life. So thank you very much once again for sharing that experience.
It's now my great pleasure to introduce Ms. Peggy da Silva, Chief Nursing Officer of St. Vincent and the Grenadines, who will deliver the presentation on the scope of practice and the regulation frameworks for advanced practice nursing in the Caribbean. So, Ms. Peggy da Silva is the Chief Nursing Officer of St. Vincent and the Grenadines, with more than 39 years of experience in nursing, midwifery, nursing administration, and health leadership. She is a registered nurse, registered midwife, and family nurse practitioner, and currently leads the National Nursing Services workforce within the Ministry of Health. Ms. Da Silva has held several regional leadership roles with the Caribbean Regional Nursing Body, and including the chair position of the RNB, and currently is the chair of the subcommittee responsible for the development of standards for the advanced practice in nursing, education, practice, and regulation in the Caribbean. So, Ms. Da Silva, thank you very much for joining us, and the floor is yours.
Thank you so very kindly. Good afternoon and happy International Nurses Day to our K-Plus heroes. And warm Caribbean greetings to all from the beautiful island of St. Vincent and the Grenadines, the gem of the Antilles. It is my absolute pleasure to speak to us today, specifically on the scope of practice and regulatory frameworks for the advanced practice nursing in the Caribbean. The presentation was compiled using information from various sources. As such, I'd like to thank my colleagues who contributed significantly and to Dr. Bolastig of PAHO. In light of the quality of the audio and so forth that I've been having here, I'm not certain if it's affecting other persons. IT has requested that I turn off the video and just use audio, so I am just seeking permission where that is concerned. So on to the next slide. So to give some context, when we speak about the Caribbean, the regional nursing body, which I'm representing here for the Caribbean, it is an organ of CARICOM. CARICOM was established in 1972 as an advisory body to the health ministers on matters related to education, practice and regulation of the nurses and midwives in the region. It is a body that embodies chief nursing officers and chief midwifery officers in the region. Next slide, please. So when we speak about CARICOM or the Caribbean Community, it was established by the Treaty of Chaguaramas in 1973, and we had a revised treaty in 2001 to include the single market and economy. The secretariat is located in Guyana, and it currently consists of 15 member states. As you can see in the dark blue, it has 7 associated states, and it also has some observership states. So we are comprised of English, French, and Dutch-speaking countries in the region. Next slide, please. So in terms of some background where our nursing education is concerned, our basic nursing education training is offered mainly in community colleges and university level in the Caribbean. So before, a lot of the training used to take place within the Ministry of Health, Wellness and the Environment. But because the Bachelor of Science is the entry level for nursing practice, we migrated to university levels and college levels within the region in keeping with international standards. But we still do have some community colleges that offer the degree, associate degree as well. And also some countries offer both the associate degree and the bachelor's degree of nursing. At the end of the training, the bachelor's degree is a 4-year training and the associate degree is a 3-year training. At the end of the training, whether it's associate degree or bachelor's level, there's a standardized licensing examination called the Regional Examination for Nurse Registration. And 11 of our countries participate in that examination, which allows for reciprocity across the region as long as the registered nursing students pass that examination. They can practice in any of the CARICOM countries as long as they have that license. Where the advanced practice nurses are concerned, they typically follow a pathway of the registered nurse, midwife. Midwifery is a post-basic program, so the registered nurse midwife and or public health training followed by the specialized advanced practice nursing education. Most commonly in our region, we use the family nurse practitioner, and we also have the psychiatric nurse practitioner program. We also have the nurse anesthetist, we have neonatal nurse practitioners, gerontology nurse practitioners, mental health nurse practitioners. So in terms of the clinical specialties, most clinical specialties are offered by the Ministry of Health in some territories and tertiary institutions. The clinical specialties offered by Ministry of Health at the diploma certificate level, but the university and the colleges offer masters and bachelors. We have specialties in nursing education, nursing administration, mental health nursing, and the advanced practice nurses, as we call our nurse practitioners, nurse anesthetists, gerontology nurses, and so forth. It's only one university in the region that offers this program, and that is in Jamaica, Mona, Jamaica. Some countries like Bermuda and so forth, they seek training external to the region, which we welcome those sort of training as well. And we do have persons employed in the region with training outside of the region. Next slide, please. So international versus Caribbean context. When we speak about the advanced practice nurses, in terms of the ICN definition, it speaks to a generalist or specialized nurse who has acquired through additional graduate education, the minimum and master's level, the expert knowledge base, complex decision-making skills, and clinical competencies for advanced practice nursing. While we have clinical nurse specialists, sometimes we refer to them also as advanced practice nurses in the Caribbean, right? These are nurses who provide expert clinical advice and care based on established diagnosis in specialized clinical fields of practice. Next slide, please. Next slide, please. So continue in the Caribbean, the term nurse practitioner, as we said before, is used. And this is an advanced practice nurse who integrates clinical skills associated with nursing and medicine in order to assess, diagnose, and manage patients in primary healthcare settings and acute care populations, as well as ongoing care for population with chronic illnesses. Now, in the region, we are mainly based in primary health care, but there are some countries, like for instance, Jamaica, where we have nurse practitioners working in the hospital setting. Key attributes: we function primarily in primary care settings, as I would have said before. We can diagnose, prescribe, and treat clients. And our scope of practice is country specific. Because if you remember the slide I had before with CARICOM, where I said that we have 15 member states, 7 associated states, and we have states with observership statuses. We have English, French, and Dutch speaking countries. Each country, although they're part of CARICOM, they have their own unique laws that governs the nurses in their countries. Next slide, please. So the Nurse Practitioners Program that was introduced in 1977, it started in Jamaica with the first cohort of 25 nurse practitioners graduating in 1978. And in the Eastern Caribbean, making up St. Vincent, St. Lucia, Dominica, and so forth, that program was initiated in St. Vincent and the Grenadines by PAHO in 1980. And it ended in 1986. So we had persons coming into St. Vincent and the Grenadines from all these other territories to train as nurse practitioner. And that training took place for 10 months of theory, and then they had 6 months of internship. And the internship was done in the various territories that the participants came from. So they would go back to their country and they would have their 6 months internship there. And in each country, the district medical officer did the supervision for the internship. Next slide, please. So this was introduced because of a shortage of physicians and the growing population in primary health care. So because that was happening, they looked towards nursing, of course, and to seek to fill those gaps after training persons adequately. So in that sense, they were looking to strengthen a primary health care, and that continues up until today. Next slide, please. So context and complexity of the advanced practice nurses in the Caribbean. Rising burden of non-communicable diseases. We are all aware of that. And nurse practitioners are working within their various territories with diabetes, hypertension, cancers, asthma. We work with all these non-communicable diseases. The global interest in improving mental health. We have the mental health nurse practitioners as well, and well-established benefits of the APNs. We can't underestimate that. So we have a well-established benefits of APN, which provide an effective option for managing the population health, and the evidence speaks for itself. There is an inconsistent definition, though, and the integration of advanced practice nursing across the region. Because, as I said before, the definition, we have to, different countries refer to different categories of staff as advanced practice nurses. So there is an inconsistency in terms of definition and integration of the advanced practice nursing across the region. Next. Challenges with implementation of the advanced practice nursing in the region. So PAHO did a study, and some of the information that was garnered from that is that where the advanced practice nurses are concerned, of course, the nursing councils, they are the regulatory body for nursing, and they include the nurse practitioners in all countries. Legislation, well, under the General Nursing Council, this is a body that is the regulatory body that registers, license nurse practitioners and other nurses. While there's an existing legislation in some countries, they are not enforced or they are non-existent in others. St. Vincent and the Grenadines is the only country in the region, in the CARICOM region, with full legislation. So, and as I said before, there's only one institution in the Caribbean that offers a nurse practitioner program, that is the UWI Mona campus. And the practice and scope, because we are speaking about the scope, while there is existing scope of practice in some countries, they are not enforced or they are non-existent in others. In some instances, the scope is informed by the medical doctor and they are not legislated for. Some legislation, licensure, while they're an existing registration, in some countries, they are either not enforced or others non-existent. Next slide, please.
Tino da Silva, sorry for the interruption, but in light of the time, we would kindly ask you to begin concluding. Yes, thank you so much.
This slide is just showing the different countries. You can have a snapshot and where they are in terms of their regulations and scope of practice. Next. So the legal and regulatory status, like I said, only St. Vincent and the Grenadines has clear legislation and recognition of the nurse practitioner role within existing law. In contrast, countries such as Grenada, Jamaica, and St. Lucia rely largely on policy-based authorization or partially developed legislation, resulting in unclear scope of practice and inconsistent enforcement. The Bahamas currently lacks finalized APN regulations, which they are working on, and this is leaving nurse practitioners operationally deployed but legally undefined. Next, please. Scope of practice and autonomy. Across all settings, nurse practitioners predominantly function in primary health care with responsibilities that include chronic disease management, antenatal assessment, school health and limited procedures. Prescriptive authority varies substantially, ranging from broad formularies, excluding narcotics initiation in St. Vincent and the Grenadines, to highly restricted physician-dependent prescribing in Jamaica and the Bahamas. Diagnostic authority is similarly constrained, often requiring physician approval for imaging and advanced tests. Next, please. So this also is a diagram that depicts the complexity of the regulatory framework. Next, please. Challenges with the implementation of the advanced practice nursing in the Caribbean. Differences, as we said before, in the definition of APNs. Example, clinical specialists are considered APNs. Variation in the scope and practice of the APNs across the region. Inconsistent inclusion of APNs in legislations and policies related to NCDs and mental health. Next. So to close off, important considerations, the way forward, close gaps by drafting policies, including legislations to close the gaps in existing regulatory structures, alignment of country legislation with internationally accepted practice, and clarify standardized qualification requirements for advanced practice nursing versus nurse practitioners. Thank you very kindly.
So thank you very much, Tino da Silva, for this excellent informative presentation. So your remarks provided a very important overview of the progress, complexity, and diversity of regulatory frameworks for APN across the Caribbean region, and also demonstrated the strong potential of APN roads to expand access and respond to priority health challenges in the Caribbean. So thank you again for sharing these perspectives with us today. And now, thank you so much. We are also honored to welcome Dr. Angelica Fernandez-Zon, who will deliver the presentation Family Nurse Practitioner Practice in Primary Health Care. Dr. Gizon is a nurse educator, clinician, and national speaker with expertise in nursing education, APN, and global health advocacy. With doctoral training in both medicine and nurse, as well graduate studies in healthcare management, she brings an interprofessional perspective of the health workforce, development, and the strengthening of the health systems. She serves as a faculty member, clinical instructor, and nurse practitioner with a strong focus on leadership, emergency medicine education, and student mentorship. Dr. Fernandez, thank you very much for being with us today. This is the first.
Good afternoon, and thank you so much to Tahoe for the invitation to join this celebration of International Nurses Day. It is an honor to represent the family nurse practitioner community and to share a practical perspective grounded in clinical practice. So when we talk about primary care setting, so primary care is absorbing rising complexity and demand. Communities need timely access to clinicians who can assess, who can diagnose, who can manage and follow patients over time. In the United States, the NP workforce has grown by more than 50% in the last decade, reflecting this need. Advanced practice nursing or nurses strengthen the capacity, the continuity, and prevention and bring a whole person, community-centered lens to care. So let's think about who the family nurse practitioner is. So she or he is a primary care clinician across the lifespan, integrates advanced assessment, diagnostic reasoning, and management. Pretty much they serve as a consistent point of contact for patients and families. And in the US, so 88% of the US NPs are certified in primary care. Positioned at the intersection of clinical care and community needs. So the family nurse practitioner is a primary care clinician across the lifespan. Our training integrates advanced assessment, diagnostic reasoning, and management with a deep understanding of our community needs. We often serve as a consistent point of contact for patients and families. And again, just like what I've mentioned in the United States, 88% of our NPs are certified in primary care. So we have other specialties like the nurse anesthesia. We have also the women's care. We have the psych NP and a lot more. Pediatrics, okay, yeah, NP. So pretty much, we pretty much reflect the central core we play in the first contact, continuous, and comprehensive care. So scope of practice in primary health care. So in primary health care, the FNPs or the family nurse practitioner conduct comprehensive assessment, diagnose and they manage acute and chronic conditions, order and interpret diagnostics and prescribe medications. We also provide preventive care, counseling, and health promotion. And these are the core elements of a strong primary care system. Today, there are more than 278,000 NPs who are actively practicing in the clinical roles in the United States, contributing directly to access and continuity. I am going to share with you the latest data later on. So professional autonomy, what it looks like in practice. So autonomy is foundational to advanced practice nursing. Within regulatory frameworks, FNPs exercise independent clinical judgment. They initiate care, and we collaborate purposefully with physicians and interdisciplinary teams. This autonomy pretty much reduces delays, improves continuity, and strengthens patient trust. It allows us to respond quickly to community needs, especially so in higher demands for underserved settings. So let's move on to the daily practice realities. So in daily practice, FNPs manage diverse patient populations or panels. They establish acute presentations and adjust treatment plans based on the patient response and lived experiences. We navigate social determinants every day: transportation, food access, medication affordability, and integrate those realities into our care plans. Long-term therapeutic relationships basically are our hallmark of the FNP practice. So these relationships directly influence adherence, early intervention, and outcomes. Let's take a look at a case example, primary care in action. So here is a composite example that is going to reflect common primary care realities. So a patient represents with uncontrolled hypertension and limited access to specialty care. The FNP now performs a full assessment, initiates evidence-based therapy, orders labs, screens for social factors affecting adherence, and provides education. So with consistent follow-up, the patient achieves improved blood pressure control and reduced symptoms. This is the kind of impact the FNP makes every day in primary care settings. So now our outcome is we have an improved control, we reduce symptoms, we strengthen continuity of care. So now let's go and look into the impact on access and equity. So advanced practice nurses expand access in underserved areas, reduce avoidable emergency visits, and improve continuity for chronic conditions. Globally, the nursing workforce now exceeds 29.8 million. And advanced practice roles are increasingly recognized as essential to strengthening primary care because FNPs are embedded in the communities and we often deliver care that is culturally responsive and aligned with our local needs. Let's go and look into the system level value. So at the system level, FNPs strengthen primary care infrastructure, improve patient satisfaction, and reduce strain by providing timely, autonomous care. So in the United States, only 27 states are approved for full NP. We were given like full practice privileges. Okay, so we still have to work on the remaining states. So APN roles are now recognized or emerging in more than 70 countries, reflecting a global shift, advanced practice as a strategy, okay, for universal health coverage. Now, what are the opportunities for the region? Across the region, there are opportunities to expand the APN roles, strengthen regulatory frameworks, and invest in advanced education and clinical training. Now, the International Council of Nurses, NP-APN network, now includes 141 member countries, demonstrating a strong global momentum. Academic practice partnerships can accelerate that growth, and APNs can play a central role in addressing chronic diseases and access that gap. So here is my closing message. So again, thank you so much for the opportunity to contribute to this important conversation. As we look across the region, one thing is very clear. Primary healthcare systems are under increasing pressure, and communities need timely access to clinicians who can assess, diagnose, manage, and follow patients over time. Advanced practice nursing is one of the most effective strategies we have to meet that need. Family nurse practitioners are advanced clinical, they have like advanced clinical judgment, they have autonomy, and a community-centered approach that is going to strengthen continuity. I've mentioned that numerous times because our patients need continuity of care and improves outcome. The evidence is consistent across countries. When APNs are integrated into the primary care, access expands, quality improves, and patients experience more coordinated, person-centered care. As APN roles continue to grow globally, there are real opportunities for countries to build regulatory frameworks. I think that's what we need. Strengthen graduate-level education and develop academic practice partnerships that support safe, high-quality implementation. The momentum is already here. More than 70 countries have APN roles in place or emerging, and 141 countries are engaged in the ICN NP-APN network. So my hope today in today's discussion is that it's going to help clarify not only what APNs do, right, but how these roles can support stronger, more resilient primary healthcare systems. And I would like to mention our latest data. I have not included that there, but I think it's very, very important to take a note of like how many nurses or NPs are there in the world, right? So 461,246 licensed NPs in the United States as of 2025. And that is by the American Academy of the Nurse Practitioners. This is the most recent and highest confidence national count of our licensed NPs through our ANP. And there are pretty much 300,000 plus NPs in 2023. So you can see an increase of around 8.5 from the prior year. So there are around 280,140 NPs who are actively employed in patient care, and that is based on the Bureau of Labor and Statistics. So the NP workforce growth, so the NP profession pretty much, grew 38.5% between 2024 and 2020 and 2024, and that is one of the fastest growing roles in the US healthcare. So again, it is pretty much, depending on the data source, the US NP workforce is going to range from 280,000 actively practicing clinicians to over 460,000 licensed NPs, reflecting a rapid growth and pretty much, demanding roles in primary care. Thank you.
So thank you very much, Dr. Fernandez for this inspiring presentation. Your remarks provided a very practical and compelling perspective of the role of APNs in strengthening primary health care and responding to the growing health care demands. So the reflections that you shared today here demonstrate how APN can enhance timely access to care, strengthen prevention and chronic disease management, and support more resilient and responsive health systems. So thank you again for sharing your expertise today.
Thank you so much for the invitation.
Muy bien. Ahora estamos llegando al final de esta sesión.
Very well, we're arriving at the end of this International Day of Nursing. And this presentation, of course, today's discussions, essentially what we've said that we have to strengthen our healthcare systems, broaden access, and improve the quality of care, and move toward healthier societies. And all of that can only happen if we increase the labor force of nursing. And I think all of the experts on this subject matter with us here today. And to close today's event, once again, we'll hear from Benjamin Portes, Chief of the HR Unit for Health of PAHO, for some closing remarks. Thank you. And special recognition to our Master of Ceremonies, Bruna Moreno, who helped us with this day of celebration. I would like to offer a different message. We're here among friends of the nursing profession and those who are watching us from afar. We're all here because this is a topic of interest to all of us. There are very few people, if they exist at all, who don't believe in nursing, especially among those with us. And that's the crusade we have to carry out. Not long ago, at an event at Johns Hopkins University, that I attended, and we were talking about who is it we have to convince. It's not us. We're already convinced. This is the time for you to take some of these matters, two of which we've spoken of, planning and advanced practice nursing, and that they become beachheads to reach those who don't yet understand what the role of nursing is, keeping us from, keeping nurses from achieving leadership roles. For anyone who doesn't work this into the national policies, does not take into account the important role of nursing and to come up with primary health care-based care models. We're not the ones who are the non-believers. It's easy to talk among ourselves and actually have to convince each other of anything because we are already believers. The challenge is outside these doors to take up this banner and to take it to those places where there isn't yet this consensus, where it's still not understood what the role of advanced practice nursing is, even professional environments that are not opening up to this idea. There are ministries of health that don't yet understand that without nursing, we're not going to address the neglected diseases and offer the proper treatment, and limited access to healthcare would be even more limited without nursing. This is the message I have for you. For all of us here, we have 2,000 people. That's always been an achievement to convene so many people, not just in the region of the Americas, but in other countries, other continents. And the message is the same one. Friends, those of you who took part remotely, virtually, come from countries that, those of you who aren't in the Americas, it's the same commitment, because the same commitment is everywhere. And we continue waging this fight, not just here, but in many other places, theaters, and will continue to do so. The Pan American Health Organization, as you said so kindly and rightfully, and I thank you for the very encouraging words. A number of countries, Guyana, Chile, have said it, where they mentioned the role that our organization played to foster progress, the advanced nursing practice. That just spurs us to continue, especially at the unit for human resources and health, that has the responsibility over that subject matter. That we continue doing this work, that we lean on you, our traditional partners in the academic sector, so that we can meet these goals and to come up and to create more resilient healthcare centers, hospitals, and so forth, healthcare systems. And so, happy day of International Day of Nursing, and thank you very much.